Welcome, everyone. Thank you for driving these long distances to be with us. We're just going to try to get started vaguely on time. I'm hoping the patients aren't going to eat all your food, though. So I do need some. We're just getting used to this space, and this is a patient treatment area, so it's perfectly reasonable for them to think if there's a beautiful spread of food, it's reasonable to have some. And we're certainly willing to buy extra. We're just getting used to our new home that Stanford gratefully is providing us. Thank you so much, Dr. Nurali Vora of the Stanford Stroke Center, for providing this space for us, and Poonam Gurukshakar from Blue Shield for inspiring us to start our newest community here in the Bay Area. We also have is Jeannie from Johnson & Johnson, who's helping us as well, along with Genentech, but I think they're on the other part of the country right now. So what we're trying to do here in Silicon Valley is break new ground. This is the fourth RightCare University of Best Practices that we've built in California on the basis of let's use the available public data about performance and about need to drive a quicker uptake of clinical best practices. We have we're very blessed to have Dr. Jim Dudl from our first community that we started in San Diego with us to teach about just a very practical approach that we successfully deployed there to impressive good results. And many other people that I could introduce, but I think that it's best that we go around the room, and we'll start with our co-chair, Evelyn Stock.
Well, hi, thank you for coming today, and I want to thank everybody for being here. And I am a cardiologist at Ucsf, and I'm very interested in starting this University of Best Practicing and expanding it from here.
Hi, I'm Jim Dudl. You're going to hear way too much from me in just a moment, but I am an endocrinologist, recently retired from Kaiser Permanente.
Hi, my name is Winston Wong. I'm a family physician. I've had the role of being the medical director for community health at the National Program Office of Kaiser Permanente for 16 years.
Hi, Ashok Krishnaswamy. I'm a non-invasive cardiologist at Kaiser for 18 years, clinically and do a fair amount of research in geriatrics and geriatric cardiology. And I think I'm coming to this really to first get an understanding of the overall process, and then second, really try to get a deeper understanding of how this can impact older adult care.
Good afternoon, Ed Udi. I'm a family physician with Holland Medical Foundation, part of Sutter Health. I serve as their Chief Quality Officer, and I'm also a practicing family physician for the past 20 years.
I'm Joe Skye. I'm an invasive cardiologist and chief at David Grant Medical Center at Travis Air Force Base, and recently a co-chair for the Sacramento group as well.
Our Sacramento RightCare co-chair, Dr. Joe Skye, the Air Force guy.
I'm Juliana McMillerin for American Heart Association. We're excited to be a part of RightCare initiative. Hattie's been very gracious in helping move hypertension control and bring a champion forward. So we appreciate the opportunity to collaborate with all of you and share new cholesterol guidelines. And we're moving into diabetes world, so look out.
Hi, I'm Shiv Adams, clinical cardiologist, and invasive and non-invasive for many years, and recently retired from seeing patients and developing other programs in integrated and preventive cardiology.
Hi, I'm Carol Zara. I'm a cardiologist, electrophysiologist. Now I'm a medical director at HealthNet and co-chair at the LA University Best Practices.
Hi everyone, I'm Poonam Garakshakar. I'm one of the regional medical directors at Blue Shield, California. And my background is in internal medicine, hospitalist for over 15 years. I'm also board certified in hospice and palliative care medicine. One of the reasons I'm here is because I work with my medical groups, especially all the ones that you've listed in Santa Clara. They're pretty much all mine that I work with, to talk about the Right Care initiative and how do we continue this work that you're doing all around California.
My name is John Overclough from the Karolinska Institute in Sweden. I won't say any more on this, and that my background is clinical psychology and public health, but I'm working on implementation of best practice in different ways at the moment.
He's also been a technical expert for Right Care for many years and consults with us from Sweden when he's not visiting California.
My name is Jack Wetzel. I'm a family physician and health service researcher. Recent transplant to California, was at the University of Colorado School of Medicine for 25 years, and now here for the last year. I direct the Whole Person Care Program and the medical director for Healthy Communities branch of the Public Health Department. I'm here because I think we as physicians, public health organizations, community groups have gotten lazy about cardiovascular disease. 25 years ago, lots of people died of heart attacks, and there was a big push. Call, go in, 5 minutes, 911. And then the last 10 or 15 years, I think we've gotten a little complacent, and we've sort of stopped some of the aggressive treatment and certainly public health messaging, I think, around cardiovascular disease. I think we have a place to go. So I hope we can talk about sort of a cardiovascular moonshot.
Hello everyone, my name is Louisa Durand. I'm a practicing endocrinologist with John Muir in the East Bay. I'm also board certified in obesity medicine. I'm actually here in the capacity as a vice chair for the American Diabetes Association, Silicon Valley, Northern California Community Leadership Board, and really excited to hear more about today.
Hi, I'm Jennifer Bryant, and I'm staff for American Diabetes Association and the lead in Silicon Valley. I know Julia actually because I worked at American Heart Association prior and have a deep connection to diabetes and heart disease through my family. But I am here because we'd love to collaborate with what you're doing at American Diabetes Association, and I'd love to learn more about that. And we are trying to do our best to bend the curve. Myself, my job is really more development, so I am the person that helps the community and the patients and support them in all ways possible.
Hi, I'm Bob Kaplan. You'll hear from me in just a couple minutes. But I'm a health services researcher. I'm currently a faculty member here at Stanford, and I have been hanging around the Right Care initiative for more than a decade.
Hi, I'm Steve Sidney. I'm trained as an internist. I'm a senior research scientist, director of research clinics at Kaiser Permanente Division of Research in Oakland, and primarily do cardiovascular epidemiological studies, and had a lot of interest over the last few years in publishing some data regarding mortality trends in this country in Kaiser Permanente from cardiovascular disease, and also done a lot of basically volunteer work for public health over the last 15, 20 years.
So I am just going to ask you to speak up more, Steve, because the other Steve Shortell is on the phone trying to hear everyone. If we can just, could you just say a couple words, Steve Sidney, about the Cardia study?
The Cardia study I've been involved with since it started in the mid-1980s. It's an observational study of the evolution of the cardiovascular risk in people who were originally young adults back in 1985 when the study started. So the original group, we were one of 4 centers at Kaiser Permanente in Oakland at our Division of Research around the country, other being in Birmingham, Alabama, Minneapolis, and Chicago. Recruited 5,100 people at that time and have been following them for over 30 years now, done a baseline and 8 follow-ups, and have a 35-year follow-up exam scheduled to take place next year, and we learned all kinds of things about these folks.
Hi, Dr. Shortell. Can you hear us? Is that better? Okay, great. This is the volume by which everyone should speak today. I'm Claudine Wu. I'm a visiting research scholar. I'm not a real doctor, just a PhD, but I play one on TV. Thank you.
And she's writing a book about cardiology right now.
With Ezra Amsterdam at UCS.
Shoot, I just want to be your sidekick. So. Jeannie Rizzuto with Johnson & Johnson, and we've been involved with RightCare for quite some time down in Southern California, over in Sacramento, and now in assistance on your new location. And J&J with their credo is very much with patients, provider, and community first, and very much be viewed as a healthcare company. And there's a lot of different resources that we provide that are non-branded, that can be utilized if it's from digital coaching to patient engagement and medication adherence. So those are, I know several people in the room, a lot of your health plan and so forth have used some of our pieces as well.
Hi everybody, I'm Laura Simon. I lead the California Quality Collaborative, which is a program of the Pacific Business Group on Health, and really excited to be here.
And hi, I'm Nirali Vora. I'm an associate professor here at Stanford in the Stroke Center, and stroke is not the sad stepsister of MI, but should have an important place alongside it as we're all working together. And I'm really excited about the vision about getting towards zero and zero preventable deaths. And I'm really looking forward to having all you as stakeholders in the room as we do that over the coming months, years, decade. And with that, I think we will start with Dr. Dudl is up to help inspire us. I mean, I think when we think about population health, I was telling him that it's a little bit overwhelming to think about how can we make an impact. And many of you who have been involved with the RightCare initiative have done so amazingly, especially in San Diego and LA and other locations. And so I hear that Dr. Dudl is going to make it all packaged so that we understand it and can really feel the power of how we're going to be able to make implement and make changes in our community. So, Dr. Dudl.
Thank you. Well, good evening, everybody. Welcome. By the way, we had a wonderful session with your two co-chairs and folks in this room. I am 100% sure that you could implement a program that will drop heart attacks and strokes in this community, having talked with these folks. They're well motivated, they can understand what's going on. I'm going to show you a couple of things. I'm going to teach you 5 principles of how to improve population health, because it's quite different from the usual kind of thing that we deal with. So, and we're going to use heart attack and stroke, what we did, as an example. So you're going to learn both what it is that we did, and then the principles behind it, so you can vary those yourself. And now I think we're going to have a 5-minute video. We were talking about making things that we even show to patients, and thanks to Winston Wong that we did this, by the way. I'm going to spend 25 minutes talking about this, that you're going to learn all in 5 minutes, and if you don't listen to anything else I say, you got the whole thing. So go ahead.
I'm Dr. Jim Dudl with the San Diego Be There program, and I want to discuss a simple, evidence-based approach that has prevented thousands of heart attacks and strokes in people with diabetes or high blood pressure or who are at high risk for heart disease. You might already know that people with those diseases are 2 to 4 times more likely to have a heart attack or stroke than those without it. But did you also know that over 60% of them die of one of those events? And many of those deaths can be prevented, but the scientific evidence on the most effective way of preventing them may surprise you. For people with diabetes, We used to focus on achieving near normal sugar control, but new results from the trial show that this approach does not work at preventing deaths. In fact, it slightly increased them. Evidence shows that what is most important in preventing those deaths is taking a cholesterol pill called a statin and an ACE pill such as lisinopril. And even better, if the blood pressure is high, we combine that lisinopril with a blood pressure pill called a thiazide for double protection. You may be wondering, aren't most patients with diabetes, heart disease, or high blood pressure already using these? The answer is no. More than half are not treated. Why is this? Well, one reason both patients and practitioners might agree on is that starting and maintaining these pills is just too complicated. Imagine the steps. First, you need to measure the cholesterol and blood pressure, then repeat it at another visit, then start the medicine, then another test, then another visit to titrate if needed, then repeat that over and over till the goal is reached. It's just too many hurdles. All of that could be pretty discouraging, but let me share with you how we implemented a simplified approach. We launched an ALL initiative to start 3 fixed-dose pills at once. The A stands for aspirin, the L for the lipid-lowering pill, the statin, and L for lisinopril. But if the blood pressure is high, we now combine it with the thiazide and call it TALL, or TALL. These drugs protect against all 3 artery changes needed to produce a heart attack or stroke. First, the cholesterol plaque growth is slowed by the lipid-lowering statin. Next, the chance of a crack in the plaque may be reduced by the lisinopril and, if needed, the thiazide. But even if it does crack, the aspirin blocks the clot that suddenly causes the attack. Not surprisingly, we found that after 3 years in 70,000 patients with existing heart disease, high blood pressure, or diabetes over 55, who took both lisinopril and lipid-lowering pills, reduced their heart attacks and strokes by more than 60%. Better yet, the healthcare system actually saved money through decreased hospitalizations and even dropped the patient's costs by using generic pills that cost less than 25 cents a day. Finally, we have shared this 3-pill approach with more than 80,000 patients at the safety net clinics. Keep in mind, although the bundle is simple, taking it daily isn't, but it's the key thing to do. Here are some steps to start a program that you can take now. First, engage and get commitment from your clinic leadership, providers, and healthcare team, including coaches, front desk staff, nurses, and pharmacists. Next, identify at-risk patients using tools like a diabetic or high blood pressure registry and the new American Heart Association Cardiovascular Disease Risk Calculator. Then empower, engage, and educate patients to take their pills. Finally, document outcomes and change your plan until you hit your goals. Yes, it's a lot of work, but let me ask you, if your patient was a relative or friend, wouldn't you want them to be offered this pill bundle that evidence shows might save their life? And last, to start all and tall. If not you, who? And if not now, when? And thank you for your time. This program was created and made available by Kaiser Permanente's Community Benefit and a grant from the United States Department of Health and Human Services.
And that was Winston Wong.
Thank you, Winston. Thank you, Jim.
Jim lost about 10 years in California.
Okay, so So the principles are 5 principles. Every one of those is going to be underlined, bolded, and in italics. So you're going to catch them as we go. And we're going to talk about the population's health. We're going to actually say the goal is to move the whole population, not individuals. And so we are going to, what am I doing? Oh, there's a click. There, okay. So, what are the 5 principles? The first is, what are the criteria for implementing a program? Because we're talking about implementation. We talked about that this afternoon. It's really all that we're talking about implementation, not a lot of theory, whatever. What does it take to do things? What potential impact could it have? That's question number 1. If it's a mediocre, small amount of impact, no matter how neat it is, it's not going to move the population. Who do you need to target to get that impact? What evidence do we need to start a program? Do you need 2 randomized controlled trials? What do you do? And I'm going to say there's 3 things that are really important. Cheap, simple, and easy. And we're going to cover why that has to be. And if it's not that, it probably won't work. This is the most important slide, how you have to track some metrics and hold people accountable to them. And we'll cover that in detail. If you don't do that, it probably won't work. So these are little subtleties that people don't know about that you have to do. And what's already done, Winston is going to talk about that afterwards. So the first point, actually the head of the ADA, American Diabetes Association, came to the head of public health came to the American Diabetes Association at our plenary session, and he said, look guys, if you're going to do something with big impact. So what is the biggest killer in medicine? Well, it turns out to be on the left-hand side, cardiovascular disease, when you put together heart attacks and strokes, which are both treated the same way in this presentation, that you end up dwarfing everything else. So all of a sudden, to start with, we have something that could work. Now, I'm going to bring up diabetes because we have ADA here, and that's great. What happens when a diabetic walks into the doctor's office? Almost inevitably, right from the beginning, they start talking about glucose control, which is absolutely wonderful because sugar control decreases the microvascular diseases. But macrovascular diseases are not decreased much, and you're going to see some evidence of that in just a moment. But statins, ACEs, and aspirin do work in that realm. And we've got to be sure that you don't miss that and go right on. Oh, and then, yeah, I think, let's see, did I go back? Doesn't matter. If you do focus on preventing cardiovascular disease on that first visit, you will do more good than anything else you can do for the rest of the year, because that's the biggest killer, as you just saw. If you don't do it, you're missing the biggest opportunity you'll have that year. Now, I'm not saying glucose control is wrong. It's absolutely the right thing to do, but not without doing cardiovascular. Okay, oh, I'm sorry. That's all right. Anyway, so we're going to show you this issue, and this is a diagram made by Dr. Rose in 1920. Yeah, that's fine. That's good enough. I will use my finger here for a second. Oh. And what we have on the x-axis is, in this case, cholesterol, but it should be, in modern times, the AHA-ACC risk category, or the Kaiser one, or Framingham. Any one you want to use is better. And if we find out that small dense LDL is even better and becomes part of that formula, we should add that in. And Evelyn is working on that. This is cholesterol, and this is the curvilinear risk as we recognized it. It goes up all the time. On the let's see, it's the right-hand side. What you see, these bars are the cholesterol prevalence. It's the prevalence of high cholesterol in area, 2 to 220. And you'll notice it says 17%, but it's above 20 by that arrow, and that's because the percentage there is actually it's really the percent of deaths in that bar. So we've got two things in this bar. It looks a little confusing, but I'm going to take a little time to go through them. So first of all, notice this is treating the high risk. So 30% of the deaths in this high risk tail. But notice this, almost 60% of the deaths are in this medium risk. And also notice that only 12% are in the lower risk. Now let's take a look, so I'm going to show you some evidence on a program called the HOPE-3 in a few minutes. And it focused just on this medium risk, and that's important because you can't move the population without including the medium risk. And that evidence does pertain directly to it. So about a little over 10% of the population, 30% of deaths, that's great. But 50% of the population, almost 60% of the deaths, and only 12% of the deaths in the lower group. So, in other words, about 60% of the population, if you could treat that with preventative medicines, you could decrease 90% of, or you're treating people that were in the 90% of the death range. And if you exclude the lowest 40%, you're only missing 12. Now, how do we find the people that are in this medium range? Easily and cheaply and simply, because every time you add a step, it's difficult. Well, Framingham, we used Framingham in this particular program because that's what we had when we were doing the program. And most people say Framingham greater than 20% 10-year risk is high risk, and between 10 and 20 is medium risk. So we took that and said, okay, let's take a look and see people with known risk factors, how many of them fall into that range? Well, heart attack and stroke, about 5%. Hypertension was almost 50%. If it was 13%, it would have been half of the 30. And the NHANES population showed in the adult population about 30% had a greater than 10% Framingham. And then if you treat each of those and you're left with the rest of the diabetics, it's only 1.8%, whereas diabetes is, I think, 8% here in Santa Clara County. So you can see that they're already treated because they had hypertension or a stroke, and you know how risky that is. And then if you look at the rest of the population that's in that 10%, it's only 10%. So basically what you have is 2/3 of the American population above a medium risk or high risk, with an MI, a stroke, hypertension over 55, or diabetic over 40, which is the criteria we used. You can see that you really do cover with that a large 2/3 of the patients. So you can easily take a look at just those people you know who have diabetes or who have hypertension or these things, and you know that you should be treating all of those if you want to cover the high and medium risk. And then if you have the ability to look at lower risk, start treating the 10%, the 9%, the 8%, and work your way down until you run out of resources. But you get the idea that you can do the most with just that top group. So how much evidence is needed? Do we need 2 randomized controlled trials? Let's go ahead and we can say the HOPE-3 is 1 randomized controlled trial. We don't have 2, but we're going to cover that. And how much evidence is needed? Well, certainty is never perfect. Rose said that. Even if we have 2 randomized controlled trials, the person sitting in front of you is not going to fit that population perfectly, or the one that walks in after him isn't. So it's never certain. So what degree of uncertainty is warranted and still implement a population program? And interestingly enough, the National Smoking Program done in the United States was done without a single randomized controlled trial. It was felt that the weight of the evidence, Jeremiah Stamler was in on that group, he said the weight of the evidence was such that they felt it was worth going forward. And we're going to talk about criteria for implementation when you don't have 2 randomized controlled trials. And then we're going to talk about modeling, because I think visualizing with a model, if it fits everything else,